Before we get into this week's episode 12, we wanted to share some exciting news with you.
Well, if you're new to caregiving or you've recently found yourself coordinating care for a parent or a spouse or a loved one, you probably know how fast it can go from we're fine to I am so overwhelmed and I don't even know what to do first or where to start.
That's exactly why we created our new Family Caregiver Bootcamp. It's a practical step-by-step workshop to help you get organized and feel more confident.
It's a 2-hour live workshop on March 26th, and registration opens on March 11th. At $37, it is really affordable and our way of giving you a cost-effective way to help and support you on this caregiving journey.
In the boot camp, we'll walk you through the key things every new caregiver needs early on. What information to gather, what to track, what questions to ask, how to create a plan that actually works in real life, and a little bit about how to talk about those tough subjects.
And you won't just leave with good ideas. You'll literally walk away with a simple 30-day action plan so you know exactly what to do next to get your caregiving journey off to an organized and less stressful start.
If you're listening thinking, that's me, or this is my sister, or, oh gosh, this is my friend, we'd love to have you join us.
And if you can't make it live, don't worry. After the boot camp, it will be available ongoing on our website under the course/education tab.
To learn more and to register starting March 11th, just head on over to yournurseadvocateconsulting.com, and we will also have the direct link for you in this week's show notes.
Okay, now let's jump right into episode 12.
Welcome back to Healthcare Redefined, advocating for aging adults and their families. Hi, this is Pam, and this is our episode number 12. Can we go home yet? What needs to be in place before we discharge? So hi, I'm Pam from Your Nurse Advocate.
Hi, and I'm Linda. If you're caring for an aging parent and you've ever felt rushed, confused, overwhelmed, especially during a hospital stay, especially when they come and say, oh, it's time to go, or you're going home tomorrow, and you're not sure what to expect or what to do, today's episode is for you.
We're talking about discharge planning, what it really means, what families should ask, and how to avoid the gaps that can maybe lead to unsafe transitions or even a return trip to the hospital. But before we jump in, I just want to share a quick note for our listeners. You may notice that we're going to take a short hiatus from releasing new podcast episodes after this one. The caregiving issues we talk about here are real and ongoing, and they're not going away anywhere soon. And we want you to know we will be back with more episodes. But in the meantime, we don't want you to, feel like you're on your own.
So you can still find a lot of practical help and step-by-step guidance from us on our website at yournurseadvocateconsulting.com, on all of our social media platforms, and especially on our YouTube channel, where we share a lot of tips and strategies to help you manage the care of your aging loved one.
So today we're interviewing a hospital social worker and a discharge planner, Marsha Hall. And really, we're going to talk about what family caregivers should know, what to ask for during a hospital stay before discharge. Marsha and I, we work together in home health and hospice, and I really enjoyed working with Marsha, and she's very good at what she does. So we're really excited to have her on as a guest for this episode. And we also want you to be aware during this episode is just what kind of things that a social worker can assist you with, especially during a hospital stay.
So we're going to cover things like when discharge planning actually starts. And when I was in nursing school, in Nursing 101, the first thing that they taught us is that discharge planning starts with admission. But unfortunately, in today's revolving door of going in sicker and coming out quicker, the difference between going home with support versus rehab or skilled nursing is a lot more complex. So we're going to be looking at what services and equipment can be arranged and help you answer the questions in regards to developing a safe plan for going home.
Marsha, thank you so much for being here. So let's go ahead and jump in. So in segment 1, what a hospital social worker discharge planner actually does. So Marsha, can you talk a little bit about what your role is before people go home?
With my role for people going home, we work closely with the team is what I call it. We work with the therapists, the nursing, the physicians, and try to determine how things are going to be looking for that person, before they're discharged. We do start this on day one. We take a little inventory. And one thing that differs for social workers is that we try to look at the whole picture of the person. We don't look just at their physical needs, their medications, that type of thing, but we look at what's influencing their decisions at home, what support they have, and those types of things also.
So, and you shared a little bit, Marcia. So, what do you think maybe is the big difference between the social worker and say the bedside nurse or the case manager or the physician or the hospitalist? What makes you different, or what's your skills that you bring to the table?
We're usually the ones that are a little bit more aware of what resources are out in the community to possibly help the person when they are after they're being discharged back home, or if they need skilled nursing. We tend to make those referrals. We make referrals to home health, supportive care services, transportation, and the ADRC is another big resource that we use a lot for many different things.
The ADRC is the Aging and Disability Resource Center, and every county has one in the United States. So wherever you're listening from, it may have a different name, but basically that's your county aging that provides services for aging adults. So, Marcia, when does a social worker get involved with someone in the hospital? Do they get involved with everyone, or I mean, how do you decide who you work
No,
with?
we don't necessarily get involved with everyone. We look at if they're going to have needs for going home is when we get more involved. And we also want to usually kind of wait a little bit longer until they're more medically stable, because it's not really fair to, be planning for someone's needs that might be able to be fixed while they're at the hospital.
Okay. So, what is one of the things that you wish families understood? If you could wave a magic wand over each family that came into the hospital that you were assisting with a discharge, what's one thing that you wish
That
families
it
could
is a team
understand about the
effort,
discharge
and
planning
we need
process?
families and patients to be honest with us about how things are going at home, not kind of try to sugarcoat it or make things a little bit less, because the person always wants to get home. So they maybe won't tell us everything that's been happening that maybe could be fixed, and or at least supported a little bit more.
That's a really good point, because there's nothing that would help to set a discharge up to fail if they're not honest. And like how many times that we've experienced families saying, "Oh, we want to take them home, we want to take them home," and then they're home for a couple of days, and they said, "This is way more than what we can handle," and then we're trying to find services. So I think that's a great point that you made. So, Linda, I'm going to let you go on and to the next topic.
Mhm. So, in looking at this and carrying this through to the next arena, let's look at the discharge timeline. Like, what happens? I don't think people understand how much work it is or what exactly happens behind the scenes. Like, we did discuss that discharge planning starts with day one, but what other information do you need? And what about insurance coverage and other kinds of common bottlenecks in regards to getting someone home in an appropriate time? Can you talk about a little bit about that?
Yeah, there are obstacles, of course, with the managed care programs. Each one of those is a little bit different. We've had some changes in our county with those plans this just recently now, and so we're finding that like a lot of the skilled nursing facilities don't have contracts, or they're out of network with one of the chief ones that's available in our county. So that's making challenges for discharge to SNFs a little bit harder. So those are things that when you are choosing your managed care program, you need to kind of look at those things to see, make sure that the facilities that you would want are covered under that plan.
And Marcia, who's responsible for finding that out?
The Aging and Disability Resource Center usually has a person that kind of is geared toward the helping people with insurance coverages. And then also, or if you have an insurance agent that you work with, they should be able to also check to see who's in network. You can call the plans directly too, and they would be able to tell you which facilities are in network with that plan.
So when someone's in the
Mhm.
hospital, I mean, who is the one? Is there someone in the hospital that before a referral is made that's checked, or how does that work, or does that fall back also on the family?
We tend to help. We're pretty much the nursing homes will know who they're in contract with, so we could always check with them. And also the home health agencies are also aware of which ones they are in connection with. So those are the two, the biggest things with the insurance companies. Generally, the hospitals have contracts with, most of the managed care programs. There's just a couple that we don't have. But if a person comes in through the ER then and is admitted, then they do get covered.
Mhm. So what type of information do you need from families to build a safe plan in regards to sending them home? What type of info do you need from them in regards to this discharge process?
I tend to ask people how things have been going at home and what services maybe they already have in place, and then kind of judge their awareness of what services are out there. Are they aware of Meals on Wheels? Are they aware of, different transportation type things? Are they aware of different supportive services? Those types of things. And then kind of what the house layout is. Does a person need to go upstairs to the bathroom, or is everything on the main floor that they can access more easily? Are there steps to get in and out of the house? Again, we work with a therapist on those things to gather information.
So speaking of that, do you find that there's any common, like a bottleneck with waiting on PT and OT evaluations for a safe discharge, or prior authorizations, or, facilities that will accept them? Because I do know that, a lot of them have to come out and do their own assessments and evaluations, and there's no guarantee that they're going to be accepting this individual to their facility. So, I mean, do you find that those are pretty common bottlenecks in your arena?
Yes. Before physical therapy and occupational therapy jump in, usually the person needs to be medically stable. So that can delay things, a little bit too, which is understandable. And then the prior auths, they can take some time if they're going to like a skilled nursing facility or that type of thing to get those back. Kind of depends again on the insurance company. And then also, again, finding, which facility, your preference for facility might not be covered, under your insurance. So sometimes you have to look farther away and that type of thing, which delays things also.
Yeah, and I would think that would also be very hard on the family, especially if the facility is in their network, but there's no beds. So they have to go further out, and transportation and, driving an hour away, to see their loved one, because the facility they want to go that's in network doesn't have any beds available for them. So this could be pretty much a strong delay for them.
And so, Marsha, I just had a quick question on that topic. So, do you, I think a lot of times people misunderstand depending on the facility. Some, at every facility, every hospital is different. So, how do you handle if someone doesn't know where to go? I mean, do you have a list of facilities? Do you have a list of home care companies? How does that work when you're trying to find someone to send a patient home with?
Um, so yes, we do have a list of different facilities. We kind of ask their general, their preference. And then we also provide them with their 3 top choices. We provide them with what's called the Medicare Compare, and anyone can go on that website and get that. You just type in your zip code and it'll bring up the closest facilities to you. And then you can compare to see what their star rating is for nursing homes and for home health agencies also. You can't always.
Do you think that people know what those are, what they actually mean, those star ratings?
Not a lot. Some people do. Some people are a little bit more geared toward it. But most people that I work with, they go on their general opinion they've heard from
Other
people.
people. Yeah, word of mouth, I think, speaks louder
Right.
than the star rating that,
Yep.
that they do. So just, I want to speak about that. There's a kind of like this common question or this common statement that we get. We hear a lot from our clients that use the terminology, the hospital's kicking my mom out, in a day, or, and my loved one, they're always kicking him out. This is not fair. This isn't right. So what do you think the gaps are in regards to those constant continual statements that they're making in regards to, they're kicking my mom out, I wasn't aware of this. Now they're going to send them home tomorrow, and I'm not prepared for this. So what types of gaps do you think need to be addressed, and what happens with all of that when those types of statements get made from your perspective?
Well, generally we don't kick anyone out. We try, we start, like I said, we start the discharge planning, from the beginning. Sometimes people don't always like, what maybe our suggestions and answers are, or what, so that sometimes is a hardship. But, and we always have to have a safe discharge plan for anyone that's being discharged. So, that's a top priority, and insurance companies generally will respect that as long as it isn't drug out. And then the person always does have the right to appeal too.
Mm-hmm. I mean, I think a lot of it is that they're so overwhelmed with all the information that they get from day one through the admission that I just sometimes don't think that they actually are listening. They may be hearing, that, mom or dad are going to be going out and then they're not going to be here forever. We've got to find a place for them. These are some of the places that you can look at. I think sometimes there's so much information for them that they're so overwhelmed that they really just can't process everything. So it becomes more of a, oh my God, what am I going to do? Instead of, okay, let's look at this rationally and logically and see where we take this. So, I mean, from my perspective, I think from clients that I've worked with, I think that, in fact, I just recently had a client that happened. That the hospital said, well, there's nothing more we can do for you here. So you're going to need to go home. Well, the person is bedbound. The person is, not able to turn, position, get up, go to the bathroom. What do we do? There's no family around to be able to help with this. How does this work? How does this become a safe discharge with all of that?
Yeah. It's also a very emotional time. Sometimes, um, families are, especially some families, with the mobile world that we live in now, live quite a distance away. So they haven't seen their loved one maybe for the last 6 months or so, and haven't really noticed the changes because they talk to them on the phone, but they don't see the changes that's been happening. And now all of a sudden they're exposed to those types of things. So it is a very emotional type thing. It's also a very expensive, can become a very expensive type thing. Nursing homes and all the caregiving things can be expensive for the person, and so that's always a little bit challenge too.
And and it is. I mean, I think times have changed. I mean, I remember, you know, maybe 5 years into my nursing career, which is a long time ago, I worked on a unit where people could come in and come in the night before their colonoscopy and get their prep and that. I mean, things like that don't happen anymore. And people do come into the hospital a little more ill and they do go home, I mean, a little quicker than years ago because, we used to have the luxury years ago where insurance would cover everything and they could stay longer. And I think some people still think that when your loved one goes into the hospital, oh, they're going to be in there for a week or two. And oftentimes that's not the case. And I think Marsha, you made a really good point about, families that may live out of town and maybe haven't seen their aging loved ones in a while. And so I think that might be part of it too. And I think people don't understand, it's Linda and I just had this conversation the other day. It's unfortunate, but the insurance companies, whether it's a Medicare Advantage plan or another type of insurance, I mean, they really are controlling healthcare now. I mean, they're really calling the shots. And so they kind of tie our hands. We want to do what's best for our clients. And Marsha, it sounds like you guys do a great job of trying to stay on top of and getting everyone prepared. But, if they can appeal and we can help them appeal, but if the insurance company says no, and they're at risk of having to pay privately if they continue to stay in the hospital, and that's usually not a financial burden that anyone is ready, you know.
Right. And I think people being thrown into roles that they were not expecting or not prepared for, such as being a caregiver. Now, all of a sudden, you're telling me I have to someone has to stay home and take care of mom or dad because they need 24-hour care, and their spouse may not be physically able to do that. So now, where does that caregiving role fall to? Who does it fall to? So I think you're absolutely right, Marcia, that there's a lot of emotions and it's very dynamically changing and it could be a very volatile situation. It can draw some families very close, but it can also
Correct.
tear some
Right.
families apart.
Sometimes families don't agree either,
Yes.
or this house feels they can do more than they really can. So one of the things do try to do too is we try to have the caregiver come in and work with the therapist while they're working with the patient, just to see, so they have a good view of what things are going to be, at least a short term, type thing. So
And that's a great idea. So there's a nugget, there's a tip right there for our listeners is, if you have concerns or if they've had a change of condition, ask if you can come in and work with the therapist during a session and just see how, get some training and see if you are actually able and capable of being able to manage them in the condition that they're in. So that's a great idea, Marsha. Um, Before we move on to the next segment, I just wanted to clarify one thing. We were talking about giving a list for home health and home health agencies as well as skilled nursing home facilities and having them pick. I just want to make it clear. And if Marsha, if you could just reiterate this or explain that they do have a choice. Could you talk a little bit about that?
oh yes, everyone always has a choice, and they have the right to make their own decisions as long as they're able to, even if we don't agree with the decision. So if they really want to go home, even if we're not recommending it, that is their right. So, and if they have a certain facility, we try to honor that as much as possible too, with the limitations that are put in front of us sometimes.
Yeah, and I know sometimes, hospitals don't have their own home care or their own hospice or, their own home health care agency, but some do. So I think it's really important that we just reiterate that it doesn't matter where you are and if they have their own or not. You have the choice. So if you know someone that works in another home care agency and that's in your, in your insurance network and it's maybe not the one that's affiliated with the hospital, I just want everyone to know that you do have a choice. And they may say, you may hear sometimes from someone, well, we like to work with ours. It's easier. We can transition I mean, but the bottom line is that you have a choice. You have, it's your choice to choose whichever agency, that you would like to go with. And so, Marcia, do you ever come up against that at all, or probably not too much, but
Not too much because we don't have our
yep.
own, but
Yep.
it's the home health agencies it's more kind of who covers their area, and that can change to what their census loads are.
Yes.
And they might not always have like all the disciplines that they need. So then you have to try to, creative a little bit with that. So
You're absolutely correct. So speaking of that, let's move on to the next segment: home, rehab, or skilled nursing. How do those decisions get made? So, Marcia, can you talk a little bit? You mentioned about that. You work with a team concept. So, what determines whether someone qualifies for, say, home health or inpatient rehab or a skilled nursing facility or outpatient therapy? How are those decisions made and those recommendations made?
well, again, we depend on our therapists. I keep going back to that, but they do play a big factor in, helping determine if they would be eligible for those programs. And we always, the top thing we look at is what the patient wants. What, some people aren't open to having people coming into their homes. Some people are more so. Some people have a negative feeling about skilled nursing facilities. And so we've been really trying to change, that they're not the old time nursing homes where you go and you stay forever. Most of them are more focused on the rehab now, and that's what people would go for. And sometimes just going for that 1 or 2 weeks after being in the hospital can make a big difference in the person's long-term goals and life. So we try to, look at those types of things for sure. Um, we look at what their fall risk is. Are they on a blood thinner that would create more injuries or that type of thing, and work with the doctors and the therapists on those issues also. And then if there's cognitive concerns, we try to be creative in that. Everybody usually does better, in their home environment. So it's hard to judge a person that's in the hospital because they're are out of their environment and they're away from their familiar items and that type of thing. So we try to be creative in doing the therapies and such to kind of work with things how they have it set up maybe at home. That's where again where it's good to talk with the person and the family to see how things are at home.
Yeah, and could you just, and we don't have to spend a lot of time on this, but I think, people sometimes misunderstand, you know, non-medical home care versus home health. Could you just talk about a little bit about the skilled home health and the homebound requirement?
Oh, okay, yes. So skilled home health is usually covered by the insurances. So that's one of the big factors. Then it includes a nurse and therapist, and once in a while a social worker, but mainly the nurse and the physical therapist and the occupational therapist. And they come into the home. It's not a definite amount of days that they would come in. It's kind of on an as needed or what they feel is needed, where they um, look at things and work with the patient, in their own home environment. So I feel it's a real big benefit for the patient. They can also look at the home, and sometimes it's just like moving a chair 6 inches can make a big difference for getting a walker through, the room and making it a little bit more safer. It's just better. It's nice for them to be able to see the home and how things are working in the home that way. Whereas supportive home services is more where you have like a bath aide that comes in to help, once a week with um, bathing needs, or they come in and do some supportive cares like cleaning the home, doing laundry, more of those types of things. And that's usually either private pay, or if a person has a managed Medicare program like Inclusa or
A
Medicaid program,
Medicaid,
yeah,
you mean? Yep.
they
Hmm.
would pay for those types of things.
Also, I think long-term care, there's
Right,
some
right.
riders within the long-term care policies that could help cover some of those services on a temporary
Just the
basis.
difference too, with the home health, the skilled and the non is we just a lot of people don't understand that homebound concept. And usually, I wouldn't think that with a hospital discharge that they're usually, even they're not permanently homebound, they're usually homebound for, a couple of weeks as they're recovering from surgery. But I just wanted to just mention if sometimes I know when we would call and make referrals and we'd talk through the homebound status, sometimes the home health care agency would push back a little bit and say, well, I'm not quite sure they're homebound, but that is Marsha, could you just say what that homebound requirement is for our listeners?
Generally, it is where it's an effort for a person to leave the home, so they wouldn't be able to easily come in for outpatient therapy or those types of services in the outpatient world. They're generally allowed to go out for like a haircut. They can usually go out to church, but it's more, and they have become, I think, a little bit more lenient at least in our area with those requirements. I mean, but they can't be going out to eat, on the weekends, or they can't be going, to visiting family, shopping, and those types of things.
Shopping, yeah, it
It's
just yeah. Mhm.
right. It's got to be when it's an effort for that person to, be able to do those things. It's one of the bigger factors.
Yeah. It can't be a consistent
Mhm.
outing. Mhm.
Okay, thank you for that. So moving on. So what would be some of the red flags in your mind, Marcia, that would be raised when you're considering that maybe the discharge is not safe?
Um, if there's a fall risk, that's always like again one of the big things. And then like again, cognitive concerns, or if there's not a consistent person that's going to be, with that person. We hear a lot of times like, yes, I'm going to be working from home, I'll be there, but then a few days later the person's back because they kicked them out, or they said, oh, I don't need anybody here anymore, and things all fell apart. Um, so that's where again, where it's important to be honest, and the person and the family do have they have the right to make the choices. Like I said, we don't necessarily agree with them. They still do have those rights to make those choices, even if they're not maybe what we feel is the best choices. But just to be honest and with the circumstances that's going on is important. And if we see discrepancies in that, that's sometimes what I guess would be a red flag, and we try to address it.
So we hear a lot at this word thrown around a lot, and just for our listeners too, what does it mean when you say baseline?
That's always comes up almost every time. What's their baseline? It kind of means, I guess to me, what it means is that where they're at normally before they became sick, what level they were at. Were they able to do their laundry? Were they able to walk from the length of the house? Or were they, um, doing the dishes, making their meals, those types of things? Or were they getting assistance, with those types of things? What were they doing normally before they became ill that now we're maybe seeing that they can't do? Would be
Gotcha. And that's, again, maybe a good reason for them to spend a couple of weeks in rehab to get them back to where they were before, if they were, be able to do things independently. So, Marcia, how can families participate in the discharge or the decision process without feeling powerless. We know that, if their aging loved one is competent, they're able to make their own healthcare decisions. What recommendations would you have for families to try and stay involved, but to try and help them support their aging loved one versus, getting in the weeds with some of the things that we could see, like when the parents feel like they're making decisions for them. I mean, any recommendations you can give to families?
I guess, showing respect for the person that, you're working with. Some patients, are a little bit more obstinate about having their or their children or their younger person, stepping in. So they just kind of, redirecting it back, that involving the patient with the decisions being made and not kind of overriding the patient or, being more dominant, I guess. That's when we usually see a lot of issues, is when the patient feels like they're not being listened to, or, or this, a lot of times it's the spouse of the patient that feels like they're not being listened to, and, their life is changing too, possibly. So it's, be respectful of that.
Mhm, mhm. Yeah, and I know, and sometimes we hear that this is not what I signed up for, and it gets difficult. So, in your role as a social worker, do you find yourself doing a lot of family mediation in some of these situations?
Certain times, yes. I think a mediation course should be mandatory for social workers. Um, and again, a lot of times it's just people are seeing things differently, and so it's getting everybody on the same page. And, and it always comes down to what's important for the patient. It's not, and what's best for them and how to keep them safe.
I think this is really the heart of social services and this episode in regards to resources. You know, social workers are great at from my historical background, working with them, are really great in accessing and finding resources, sometimes the hard to find resources, but they really know how to coordinate and help with getting these resources. So, can you go over a little bit of the types of resources that you can help with? A couple examples would be like home health or DME, transportation. I mean, just give us a little bit of a snippet of some of the resources, because I know it can be boundless and endless and quite heavy, but can you give us a little snippet of the type of resources you can help with?
Yeah. One of the big, or one of the major things that we sometimes will refer people to is again the Aging and Disability Resource Center, just because they are kind of the organization that has the whole range of services kind of under their wing, or at least they have the knowledge to do that. And they can also help with financial needs if that's, an obstacle of getting these services. So we refer people to the Aging and Disability Resource Center for option counseling a lot of times, where they can look at the options that might be available to them, because there's so many different programs, and us as social workers in the hospital don't keep up on those different programs necessarily, and what the funding is for those and that type of thing. So that's a big benefit for them.
Now, Marcia, does the ADRC, do they help them with either Medicare advisors or Medicaid application? Can they get help, those kind of help through the
Yep.
ADRC?
Yes. The Medicare, they usually have a disability or a income person that would help with that. They can help with applying for medical assistance if that's, and then they can look at the different programs under that to see, are they, would family care be a good fit, or there's other little nooks and crannies. There's a dementia care program under the wing of the Medicaid too that can provide some extra funding for caregiver support or caregiver relief, so the caregiver can go shopping, once a week, those types of things. Like I said, I'm not an expert for sure on those different programs, but the AG and Disability Resource Center does have those things available and can talk through that much better than I could. And so that's one of the things. And we also like home health services. We look at those, make referrals for those. In our general area, there's just two different agencies that we can use, because that's who covers our area. But we're very fortunate to have them, and they've been very good about responding to our needs. Durable medical equipment, a lot of times, people don't know where to get that, how to get that. We do have a loan closet, and I think a lot of facilities do, or a lot of our hospitals do have what they call a loan closet where they can get a walker. Our therapists kind of work with that also. They'll get the walker set up so it fits them, or if they need a wheelchair temporarily. It's usually a 6-month type loan program, but it can be extended if needed also. Or if somebody needs like a commode by bedside, sometimes we have those available. The Aging and Disability Resource Centers, a lot of times they will have like a loan closet also. And then those are helpful things for somebody that needs something, especially short term. If they need something more long term, we can work with the physician to get the order placed to the durable medical equipment facility that's, can service them for like a hospital bed or for a wheelchair or a different type of walker. Medicare generally will pay for those things if there's certain criteria that is in place. So that's a good thing. Transportation, that's another thing that we can try to help set up if they have like frequent appointments. We can help provide different information for the different transportation services that are available in the area. Caregiver support, we talked a little bit about, or I guess I talked a little bit about the dementia caregiver support. Those are some of the programs that we have in our area, but I think they're also, it would be good to check out to see whatever area you're in, if there is a caregiver support, and just being able to share those needs and what you're going through with someone else that's kind of experiencing the same thing, I think is very beneficial. And then there's, we also like look at Meals on Wheels. If there's a meal site, sometimes the socialization is good for the person just to get out to, be with somebody for a while, or if they would want Meals on Wheels. We're very fortunate to have those in place in the areas.
I think, yeah, and the safety resources, could you address some of those, Marsha? I think like the we get a lot of questions about like Lifeline or Life Alert or things like that.
Mm-hmm. Yeah, Lifeline is one of the things that I frequently recommend. And I usually say it's not for you necessarily, but it's for your care, it's for your family, because then they know that you have a way to get help if needed, and it gives them a little bit more peace of mind. You usually can sell them on that idea.
That's a great, I have not heard that angle. That's Marsha, that's really good because
Yeah,
they'll always say they don't need it.
right,
Hmm. Yeah, you find it hanging in the bathroom or on their
right.
walker, or it's stuck in a
Yeah,
drawer in the kitchen.
yeah. And that's the other thing I always tell them, is that it doesn't work unless you're wearing it. So you need to have
Hmm.
it on even when you go in the shower. Keep it on because that's what it's there for. So.
What about what about things like you talked about safety resources, but what about some behavioral health? We did touch on dementia, but what about other mental health issues or substance use support?
Mhm. Well, again, the aging disability, if they are disabled with mental illness and that type of thing, there's referrals that can be made to like the family and children's centers if those are available in the area. I'm kind of talking about places that I'm familiar with, but other areas might have different places. There's different counselors if they need that type of support. We are fortunate to have like a hospice or a bereavement and grief specialist or a group that meets in the area, those types of things. So there's different programs, usually in the community. I keep going back to the Aging Disability Resource Center, but they do put together, at least in our county and our neighboring counties, a resource guide book that you can usually find online that has like the different programs that are available in the area and support type things for that. So that's another resource for people.
I think also the Veterans Administration
Mhm.
also. And
Right.
I know a lot of the ADRCs have like a place where they can, or a phone number or contact person, or an office right there within the ADRC where people who are veterans can actually just go right there and access some of the resources that they might be entitled to as a
Yeah.
veteran.
Yeah. Each county usually has a veteran service office. Yeah, for sure.
Hmm.
Yeah, let's move on to common discharge mistakes and how to avoid them. Uh we just want to talk about when we're talking about, say we're going to get home health, or say we're going to get some other kind of service in the home. who is the one responsible? Does the and this is where I see sometimes things fall through the cracks is say you discharge someone on a Friday or on a Saturday, and there's the home care agency or the someone you're trying to arrange services is not open, or you're trying to make a follow-up appointment with the clinic and they're closed till Monday. How can families, avoid that, or who makes those appointments, and how should that work?
Generally, when I make a referral, I ask the agency to contact me back about what their start date is, and not necessarily the time, but at least what date they're going to be seeing someone. I think that's kind of important because, and then I always tell the families or the patient that they're going to be getting a call because sometimes you don't recognize the number, so you don't answer the phone, which is, not a bad thing either, but it happens quite often that they don't respond. Um, so if like at our facility, if there's a need on the weekends, they usually flag us for Monday to follow up on that and to make sure that that's in place. We do sometimes find patients that will just about tell you anything just to get out of the hospital, so they'll agree to home health, and then when the home health calls to set up the time, they say, "No, I don't need that." So those types of things happen too, so families need to be aware that, it might have been set up and it might have been in place, but it might have been declined, when they were contacted, which is their right. So, I mean, I'm not saying that
It
they
is,
do that.
but it's one of those things where you could get a nasty call from, or a concern call, I should say, from a family member, but they haven't checked with their loved one first, and their loved one may have canceled or may have said, like you said, I don't need it. So that can happen. Are there any common discharge mistakes that can occur that maybe the families or the patients can help to prevent?
Um, a lot of times, Medicaid, our pharmacists, or I think most hospitals, they have a pharmacist that goes through the medications and looks for interactions and those types of things. And we always have a discharge sheet that goes home with the patient. But a lot of times, we've found that patients save the one from the previous time, and then they get confused about which one is the current one. So it's important to get rid of any old documents and just try to keep the most current, keep the current one and get rid of the past documents. But that we find that doesn't happen very often. Another thing that we always ask for is for patients not just to bring their medication list, but to bring their actual bottles of pills or their medications with them when they come in, if it's possible, because then they can look through those medications and make sure that there aren't medications that are by a different name that are, confusing for the patients, and they'll know kind of what they're actually supposed to be taking, and, put in the discard bag the ones that they shouldn't be taking anymore or that have been changed, those types of things.
And one more thing related to those medications, and I one experience I had is we had a discharging a patient had dementia. The wife was didn't come up for the discharge instructions. I mean, this wasn't my patient, but this was something that happened where I was working. And then the wife didn't come up. She wanted the aide to bring the patient down to the door so she could pick him up, and then they were going to drive to the pharmacy and pick up their medication. Well, when they got to the pharmacy, she declined the Eliquis because it's one of the new
Mm.
blood thinners, and her copay was so large. So, fortunately, in case management, we did a phone follow-up and found out that she never picked up the Eliquis. So, is there any suggestions there as far as, does should the pharmacy get involved? How can we avoid something like that? Do you have any suggestions, Marcia?
Um, Again, well, if there is a medication that, because if that is too expensive, they feel it's too expensive to, notify their doctor that they don't have it, just in case there's something, an alternative medication that they can have, that would be
But is there
that.
something that can be done, or on before they're discharged from the hospital when choosing, say, an Eliquis or as a Xarelto? I mean, how is that decision made, and is there anything that can be done prior to discharge?
Generally, I think the pharmacist will kind of um, discuss what if there's, going to be a considerable copayment.
Mhm.
They're pretty familiar with what the costs of different medications are.
Mhm.
Generally, they will, I think, give that person, a general cost if that's, a concern, or if they feel it could be a
Mhm.
concern.
Yeah, and
Um,
I think that's just good for everybody to know. If you're getting a new medication, that's a question to ask. That's
mhm.
consumer be aware, ask what my copay would be if this is, going to be expensive or if it's not covered. So that's, for our listeners, if you're going home on a new medication or your aging loved one is, ask those questions what my copays might be. So, Linda, I'm going to go ahead and pass it on to you for the next set of questions.
Okay. So we have a lot, we're a very mobile society right now. So a lot of individuals or families have sons and daughters or loved ones that are not necessarily just out of state, but also maybe out of the country. So what do you do when the decision maker is out of state? I mean, how do you handle that?
we reach out to them by phone
Mm-hmm.
and, discuss things that the physician will, the nurse will, social worker will, depending on what the needs and what questions we have. And that's not really an uncommon type thing. It's just, and sometimes we'll set up like a care conference, like a yeah, a virtual care conference or such, with that person too, depending on, what the needs are, I guess, for the patient, and what involvement the caregiver wants to have.
So
And
what documentation helps with all of that? I mean, what do you usually ask for when you're talking to someone who you're kind of wondering if are they able to make these decisions on their own? Are they making good decisions? What type of documentation are you looking for or would you ask for?
well, a lot of times we already have like a healthcare power of attorney on file. So we do look at, I always check that to see if we do have one or not. And then if there's not one, generally I'll ask either the patient or the family if there is one, and have them bring it in if they do. Um, and then, the doctors are the ones that kind of determined, whether the person is competent enough to make those decisions. So sometimes they'll rely on what's called a MOCA test from the occupational therapist to kind of determine, what the guidelines are. But a lot of times just general conversations. But typically, the physicians also don't, activate those power of attorneys, when the person's first coming into the hospital, because if they're sick, that can make a big difference in
Mm-hmm. That makes sense.
answering questions and such. So we
So
kind of,
So how do you handle, because families are very dynamic. And so how do you handle sibling conflict? Or if the POA if it's unclear who the actual POA is, because you may or may not have that piece of paper, but they say they're the POA.
we always think that, or a lot of families, or a lot of caregivers and families always think that once the power of attorney is done, that it's activated. So then
Yes, that's very true misconception. Yes.
we always have to go back and say, no, your parent or your loved one, is still able to make their own decisions. It hasn't been determined that they can't yet. And it's only, how the power of attorney only takes effect, when two doctors, or a doctor and nurse practitioner, or a doctor and psychologist have deemed them incompetent. So that comes up quite often. We have to kind of redirect that and say, those types of things. And then
But
a
they
lot of,
can defer, like a patient can defer, say, I really just don't want to deal with this. I'm too sick. Can you
Mhm.
just, my daughter's my POA, but can you just defer all questions and let her just make the decisions and sign the consents?
yeah, we tend to do that at times. We always try to make sure the patient also is aware, though, because, if they're still decisional, then they need to, at least
Yeah,
get help.
if they're directing, say, well, you've explained it. I mean, it's that's the thing about healthcare is it's never black and
And
white.
white. It's
Never
very gray
is.
and muddy.
Yes,
Hmm.
yes.
So
Social
how do
worker.
you get everybody on the same page? I mean, especially with large families, sometimes even small families. I mean, how do you get everybody on that same page so that everybody's rowing in the same way, in the same way?
Um, we have to, well, generally you have to, try to redirect them that we're all here to to work on what's best for the patient or your loved one. That's what we're all here for, and listen to them, I guess, and listen to what their concerns are, and why they think so and so is not making the right decision, and those types of things. And it, usually, when you can get them to focus back on what's best for the patient, then they usually do come around. And sometimes I've had examples. I've had one sibling in one room and another sibling in another room because they don't talk, and then you have to go back and forth between the two of them and say, but hopefully then the person does have a power of attorney for healthcare, and they have made that decision of who they feel is the most responsible person to make the decisions for them. So
Is that, speaking of advanced directives in a healthcare, is that something that in the hospital a social worker can assist a family or a client or patient if they don't
oh
have one?
yeah, we do a lot of that. We help them with that, and then it has to be witnessed by two people that aren't related or aren't directly with their medical care. So social workers are generally and chaplains are the only ones in a hospital that can actually witness those. So that's always important, because sometimes we also review all the healthcare power of attorneys that come into the hospital and clinics to make sure that they are correct. And a lot of times the biggest mistakes we see is that the witnesses dated it on a different day than the patient did, or the person developing it, or else the witnesses, have the same last name. It's like, well, I don't think this is probably kosher. So then we have to, have them get that fixed. So
You
Okay,
know,
so Pam, I'm going to give this over to
hmm,
you to
okay. And I
continue.
just have in this next segment, I just really have just a couple of quick questions as we're kind of winding this episode down. But when caregivers feel pressured or family members, there's certain things, Marsha, that we can maybe recommend, or what would be the best way for them to get their concerns addressed? And one of the things I'd like you to talk about is the care conference and what that is and when that can be requested or how that works as a tool for the family.
well, care conference can be requested at any time. We tend to hold them, you know, well, we hold them weekly with our swing bed patients, but then other acute care patients, um, we tend to hold them a little bit closer to discharge time. Try to bring everybody, if there is, especially if there's differences. Like one instance I had was the spouse really felt that they were able to take his wife back home again, and his wife had dementia and was needing a little bit more help. And so we had a care conference, and we kind of had the sibling or the children present and the husband present, and then we gave them time to talk amongst themselves too also. And they, the husband finally did come to the decision that the placement was necessary at this time. And I kind of always explain to them that, in my experience, I've been around for a while, that oftentimes it's if the caregiver is feeling overwhelmed and, is trying to do everything, they're the ones that's health usually goes downhill faster than the one that's being cared for. And I tend to point that out, especially during care conferences also, just, to kind of try to get them to realize that, and to kind of open their eyes to, why there is a concern. And that's kind of been another little effective thing that's worked for me, at least. But yes, care conference can be, asked for, or, a lot of times we ask for them when we see that there is concerns, and, how to get everybody on the same page. And we involve the therapist, usually the doctor as available, and then nursing staff
Mhm.
and social worker, of course.
And Linda, I'm going to turn it over to you for some rapid fire practical tips. So hopefully we can share
Okay.
some quick wins.
Okay. So, just just what is the best time to reach a social worker? I mean, the family has questions or concerns. What would be the best time to reach you? And what are some of the things that the patient's family or the patient should bring to the hospital when they come in to help ease their transition into discharge? And what else should they be bringing in, and how should they track all this stuff?
Um, it's kind of nice if they would have like a folder, or where they keep kind of their, you know, important papers like their insurance, a copy of their insurance card, their healthcare power of attorney, their most recent list of their medications. I still feel like it's important, just to bring in the bottles if possible, but sometimes that's not always necessary. I mean, not always available and able to do that, but bringing those documents in is helpful. And also, if you are the caregiver for the person, if you have been keeping like a notebook about what, things have been changing and occurring, if you could bring in those tips, that type of thing, that's helpful also.
What's the best time to reach a social worker case management?
Well, generally we're there Mondays through Fridays. When if the hospital has a need, they will reach out on the weekends, and we don't ever object to that. That's for sure. But generally, week or Monday through Fridays we're available. Generally mornings are a little bit more busier because we're getting people like out to the nursing homes and out to different things. But the afternoons are a little bit more where we have time to spend with someone that's not quite ready for discharge or is having some other issues or needs, that type of thing.
Okay. All right. Pam, any
Yeah.
other questions or?
No, I think we covered that. Just a couple of things as we wrap up, just to make sure, Marsha, that we covered everything. Can you give us an example? Can you walk us through a discharge that went really well and what made it work?
Probably going back to the one where the spouse was feeling that he really could take his wife home, and then he was able to come to the conclusion. The other big benefit for that is a lot of times you can't get someone into a memory care facility immediately from the hospital. That doesn't happen real often, or to an assisted living. Those don't happen very often. But this one did. The family was very they were very willing to look outside the box. I guess they were very willing to be present and do the care conference. They went and checked with the facility, did paperwork, and dealt with all the financial issues with them promptly. And we did keep the patient maybe one extra day, but it made the transitions just so much easier, because I do believe that if she had gone home with the husband, that the husband would have said no, she's staying here. And he was the agent for her. So that was one that went really well. So it's just kind of being open and being and it's not always possible, but this one was, where the family was available and they were open and they were willing to do whatever needed to be done, type thing. Check the facility out, do those types of things, talk to them.
Is there one thing that families can do to help make your job easier, to help you help them?
I guess to be open. That's like I said before, just what's the concerns, what's been working, what's not working. Try not to sugarcoat things that aren't so great going on at home. That that's a big difference. And also to be kind of have an idea of what facilities you might want, if there's if you have other several options, that type of thing. We usually will ask for we have like 3 local ones in our area. So we usually ask for first, second, and third for that, and then go from that aspect and try to meet their needs.
Is there one myth about discharge planning that you'd want to clear up? I know we talked about this a little before, but is there at least one myth you can think of?
That we're not trying to put everybody in the nursing home and take the family farm or the family house.
Okay, that's fair.
And there are so many different options out there now that it's kind of fun to try to be creative and trying to work things through. And
I know we didn't really talk about it, and I don't want to get as we're wrapping this, I just want to mention that years ago we used to rule out assisted living if they weren't ambulatory, and and now some assisted livings across the country do what they call enhanced care. They could do 2-person transfers, so I mean that really opens things up for other people. So
a lot
Marsha,
of them are even doing Hoyer lifts and sit to stands,
Yep.
and
Yeah.
They're almost becoming kind of mini skilled nursing facilities in some areas.
Yeah,
But
sometimes
it go ahead, Marsha.
yeah, sometimes I mean they do generally will accept somebody with a wheelchair now for sure. And they can have home health coming into the assisted livings also, which is
Mhm.
um another thing that might enable the person to go back to their assisted living facility and
Mhm.
have home health.
Mhm. Is there is there one thing that you wish families could stop doing or start doing when it comes to discharge from the hospital?
Hmm. There's not really anything that's really coming to mind on that one. Um,
Well, I know as a nurse, when we were going through the discharge, and I know this wouldn't necessarily be the social worker, but I think one thing I want to throw in here is have another person present with someone when they're going home. So that there is another family member or there's another set of ears to hear the discharge instructions and to because as we all know, at that point in time, the patient, they will say do anything to get out of there. They want to go home. Yes, yes, I understand. I understand. So, and sometimes they don't. So I always think it's good practice to have someone, another family member, or even if it's a neighbor or friend, someone that will be present and listen to those discharge instructions. Linda, did you have any other thing that you think that you
Nope,
can add to that one?
I just want to thank Marcia for coming to join us and for the work that she does as a social worker, supporting patients and families sometimes during the hardest emotionally challenging times of their lives.
Absolutely. And if you're listening and you're in the middle of a hospital stay right now, here are a few takeaways, for you to hold on to. And that's, discharge planning starts early. Don't wait until the day, you're told that you're going home. And, as Marcia explained, it shouldn't happen like that. There is a process. So if you have some concerns, ask for that care conference. If you're not ready or you're not quite understanding, I mean, the hospital staff and the social worker will lead that and they'll do whatever they can to help you.
Always remember that you are the consumer of healthcare. So you have the right to ask questions and to get clear answers and get clarification and get answers in a way that you can understand.
And a hospital social worker and discharge planner, they can really be a key partner in connecting you with resources and building a safer plan. So that is another really key takeaway that we want our listeners to get out of this.
So, and also just as another reminder, we are going to be taking a short hiatus from new podcasting episodes, but we're still here to support you.
As we mentioned before, you can find us at yournurseadvocateconsulting.com, on our social media, our YouTube channel, for, more tips and strategies. And if you need more help, consider a free 30-minute consultation with either myself or Linda to address your specific situation. And we will share the resources for you for that in the show notes.
So, if this episode has helped you, please make sure that you share it with a friend or a sibling or a caregiver or a loved one.
If you haven't already, subscribe. Please leave us a review. This really helps more families find us and find our podcast.
So, until next time, take good care of yourself. And Marcia, again, thank you for joining us.